Ladies and gentlemen, for those here in the audience and those joining us via live stream, very welcome to this very important session on how to manage the next decade in cancer. This session will look at how we are going to redefine life with this disease in the next decade. And I can tell you, we couldn't have asked for better speakers for this very, very important and relevant session, ladies and gentlemen. To my immediate left, he serves as Managing Director and Regional President of Oncology at Pfizer. Ladies and gentlemen, please welcome Andreas Penk.
Thank you very much. Is this on? Yes. Thank you very much, and thank you to the World Health Summit for inviting me.
And
continue, right?
Yeah, indeed. I first wanted to let the audience know who's on the panel, and then we kick it off right with introductory statements. Right next to him, he's the Deputy Director General and Head of the Department of Technical Cooperation at the International Atomic Energy Agency. Dazhu Young, ladies and gentlemen, please welcome. Delighted to welcome on stage, she's the head of the WHO Collaborating Center for Pharmaceutical Pricing and Reimbursement Policies, affiliated to the Pharmacoeconomic Department at the Austrian Public Health Institute. Dr. Sabine Vogler is here, ladies and gentlemen. Wonderful to welcome the Director of the Center for Study of Conflict and Health at King's College, based in London, UK. Richard Sullivan, ladies and gentlemen, is here. She's the Director of Special Projects at the Union for International Cancer Control, which has a membership base of over 1,000 organizations in more than 160 countries. Julie Torode is here, ladies and gentlemen. And last but not least, he's the President of the International Prevention Research Institute based in Lyon, France. Peter Boyle is here, ladies and gentlemen. Now, much to talk about, and indeed we are going to start with introductory statements, 5 minutes each. Very curious what you have to say, starting with the first of the two chairs of this session, one of them being Andreas Penk, the other being Peter Boyle. Andreas Penk, you have the floor.
Yes, thank you. Thank you to the World Health Summit for organizing this panel and for inviting us. Thank you to Peter for co-chairing this session, and to all participants for joining this important conversation. We have seen, in fact, quite a dramatic perspective from the video, I think. It showed a significant gap between, let's say, highly developed countries and developing countries. And it also showed a potential perspective that this gap may be even wider in a few years from now. And so it's very important to take action and to really discuss how we could first avoid a further widening of the already existing gap. But of course we should all be optimistic. Maybe there are also ways even to narrow the gap. So when you look at what is happening right now, and that may be a first challenge to narrowing the gap, is that progress in oncology has never been faster than today. And it's an amazing progress, which is good for patients, based on science we have seen in the video and some other developments. But what we see by now is that more and more treatments with more and more specific targets come to the clinic and will enable us to either cure some cancers, and some cancers are already curable today, or better manage most of the existing cancers in the near future. So this is good news for patients. And by the way, it's not only in the development of drugs, it's also in radiology, imaging, all kinds of surgery, all kinds of interventions we know in cancer are in fact developing at a dramatic speed. What this means is the old pattern where we had one significant introduction of a new treatment every 2 to 3 years, and then countries slowly or not so slowly adapted, this old pattern does no longer work. So we really need to figure out how we can close the gap quicker and make sure innovation can be adopted earlier. And let me illustrate it with just one simple example. So when pathologists looked at a lung cancer specimen 30 years ago, he just said it's non-small or it's small cell lung cancer, and that's it, period. No more differentiation. Today, with all the molecular targets we know, and these targets guide therapy, it's more than 20 we use already in the clinic, and more to come. In fact, every year alone in lung cancer, we see 2 to 3 more of these specific markers guiding therapy, which then leads to longer survival, and sometimes significantly longer survival. I know one marker where the survival was before treatment introduction, 6 months after diagnosis, and nowadays in the most developed countries, you can stretch survival to 7 years. So this is absolutely substantial progress for these patients. So this is the first thing. How can we deal with it? So this is important. We know countries have different starting points from their resource level and all these things. So from our perspective, one of the most important things is really to develop a comprehensive national cancer plan. So this is really the starting point to make sure countries make the best use of the existing resources. And that's something which sounds quite a common sense, but it's not done everywhere in the world. So this is a very important starting point before you talk about all the different elements, because cancer can be extremely costly if you have such a uncoordinated use of resources, if there is no existing policy framework, all these things. Of course, it's not all about the cancer plan alone, and not about the treatment alone. We heard it in the video, prevention is absolutely key. Prevention can help a lot, and also early diagnosis can help a lot. And again, this could be linked and should be linked to the cancer plan. And so in conclusion, I would say, let us focus on things which can be done in the different countries and should be proportional to their existing resource level. So this is the first thing. So let's make sure countries invest in cancer care proportionally to their resource level. Hopefully they do that in the framework of a cancer plan, a national cancer plan, a good policy framework. And that should include prevention, early diagnosis, and better access, especially to basic therapies. I mean, I talk about a lot with this very innovative therapies. Let's not forget many countries do not have access to the very basic therapies in cancer. And I'm glad that we are all here together to discuss how we can better collaborate on that, and that would be an important target for us in the next years to come for Pfizer Oncology, to bring that forward. Thank you.
So progress is being made at a rapid pace, but of course many challenges still remain, and which challenges and how to tackle them we will of course dive into more detail as this discussion progresses. But first let's get to Dazhu Yang. And Mr. Yang, the International Atomic Energy Agency is not necessarily an agency that perhaps most people here in the audience would automatically link to combating cancer. I'm very curious to hear how the two interlink.
Thank you. Good afternoon, ladies and gentlemen. On behalf of the IEA, I would like to express my congratulations to the World Health Summit and its leadership team. This summit has made extraordinary contribution last 10 years to address a very important development need, access to health services and well-being for everyone. The IEA is very proud to be a partner of this endeavor. Ladies and gentlemen, excuse me, you may wonder why IEA attend this World Health Summit. You may know IEA as our work so-called nuclear watchdog, and you may know some work what we are doing on nuclear safety and nuclear power. But actually, nuclear science and technology also have a very important role in development. And that is why the motto of the IEA is Atoms for Peace and Development. One key area of our member states is health. If anyone here has ever received X-ray or CT scan, you have benefited from nuclear technology. And it's used extensively for diagnosis and treatment of cancer in cardiology and in many other fields. So nuclear science and technology is absolutely essential component of modern healthcare. The IEA is helping its member states to use this technology for health safely and effectively. Ladies and gentlemen, the topic of this panel is relevant, important, and timely. Thank you very much for the excellent film. Cancer is one of the biggest global health and development challenges, according to the figures released this year by the International Agency for Research on Cancer. Over 18 million people will develop cancer in 2018, and there will be 9.6 million related deaths. By 2030, the figure will raise to 24 million cases and 13 million deaths. So developing countries bear a disproportionate burden. So over 60% of new cancer cases occur in developing world. And it is here that about 70% related deaths occur. So address this challenge require global attention, coordinated joint efforts by governments, national authorities, international organizations, financial institutes, and other stakeholders. Science and technology, including the nuclear science and technology, is vital to this effort. So, for example, nuclear medicine is essential for early diagnosis and treatment of cancer. And radiotherapy is an essential tool in the treatment of cancer. However, the people in developing nations are woefully underserved. 90% of people in the low-income countries lack access to this life-saving treatment. So the IEA is working to narrow the gap between the need and assessment and accessibility. For example, 25% of the IEA technical cooperation projects focused on health, in particular the diagnosis and treatment of cancer using nuclear technology. Supporting our member states, especially the developing countries in cancer care, is one of the priorities for the IEA. So we, in coordination with WHO and iPRI, provided the comprehensive assessment of cancer challenges and the national capacities of countries in cancer control. And we already conducted jointly 94 so-called impact missions for this kind of comprehensive assessment. We also help member states to develop, as you just mentioned, the comprehensive national cancer control program. It is very important at the policy level. So we transfer the technology on radiation medicine for cancer care. We support member states for the building the human capacity in using nuclear technology for cancer diagnosis and treatment. We provide expertise to help member states to plan and establishing the nuclear medicine or radiotherapy facilities. We also guide member states to establish competent authorities for the radiation safety, which is very important for the safety of patients, doctors, and nurses. So we also support partnership building and resource mobilization for cancer control. So in short, the IEA is delivering, and we are ready to strengthen our partnership with all relevant actors. So for us, by working together, we can make a real impact in the decades to come. I thank you.
Thank you, Dazhu, for telling us how nuclear medicine can indeed contribute to addressing the issue of cancer, something I'm happy to go into more detail as we get into the Q&A part of this discussion. But first, now we want to hear, of course, from Dr. Sabine Vogler, the head of the WH Collaborating Center for Pharmaceutical Pricing and Reimbursement Policies.
Thank you very much, and thank you for having me here. And my focus of work is medicines, prices, and pricing, which means that this is what I will be focusing on in my statement. But of course, all the other areas like prevention, research, and so on are also of importance. Could I have the slides, please? The session is called... It's not here. The session is called Managing Cancer in the Next Decade. And I would like to start with a diagnosis of the situation as it is today. And I hope that you all agree that, as we have already heard, that effective cancer medicines are not available to all patients. I put here in parentheses existing because I really want to focus on those medicines that already have a marketing authorization or close to, leaving out the issue of what is in the pipeline. And I would like to stress 4 aspects. The first one regards the issue of quality, so that we see that in several low and middle income countries, there are quality issues. I know here at the summit there's another session about falsified and substandard medicines. This has also to do with limitations in regulatory capacity, where capacity still needs to be built. If there is high quality regulation, still the issue of quality even comes into these countries, because there's there's also this aspect of ethical aspects that patients are eager to get medicines as soon as possible, and they might sometimes push for quicker uptake and quicker marketing authorization, which might compromise some quality issues. Second point that I would like to stress is that cancer medicines are not brought on the market. Even in Europe, where several medicines have a marketing, an EMA marketing, central marketing authorization, they are not brought on the market. And there are 2 major reasons for that. One is that some markets, some small markets, even if they have a willingness and sometimes even affordability to pay, they are not attractive enough, and I think small markets shouldn't be ignored. The other reason is that, and I will talk in a minute about the pricing policy of external price referencing, that this policy incentivizes marketing authorization holders to put medicines on markets at a later stage, so to delay it, in order not to ruin the overall benchmark price. Third aspect to address is the issue of shortages. I think we are all aware about it, and here again there are several reasons. Has of course to do also with production, with one active ingredient only supplied by 1 or 2 suppliers. I think these are global issues. And last but not least, medicines non-availability is strongly linked that medicines are not affordable to patients in those settings where patients have to pay a copay parts, and not affordable to countries in those settings where the countries have a coverage system, a reimbursement system, making the medicines available through the public coverage, but they are not affordable. And again, I would even like to bring the example from European countries. If you look at some Central and Eastern European countries, the Baltics, they can't afford it. So it's a major policy issues, and I would just like to share with you what's the way, which policies do currently policymakers use to price medicines and including cancer medicines. And a first starting point, it's a starting point, is still that many, many countries use this policy of external price referencing, which looks at the prices in other countries and is taken as a basis. And this has certain implications. One, that it can incentivize a strategic launch. The other thing is the referencing is done to the list prices, because what happens in reality, the price determined through external price referencing is not affordable for the purchasers, for the public payers. So afterwards there will be negotiations, discount agreements will be done, risk-sharing agreements, capping, whatever you call them. In Europe it has the overall name of managed entry agreements. And so some confidential outcomes are there. And in the lower part, you see which type of agreements are commonly used, mainly the discount agreements, the financial, not outcome-based. They are rather rare. Outcome-based agreements could help to provide further data, to collect data. But you also see a large portion where it's even not known which type of managed entry agreement was concluded. And what is clear, that the way that the amount of discount is not known. And as it's not known, there is some research being done about it. There's one study which was done by researchers in the Netherlands with other researchers, where they aimed to look at the real prices. And what you see below this Excel chart, that was the work which I did, because they surveyed the list prices and the actual prices, and then I looked at the amount of the discounts there. And what you see is that certain countries with a larger market, like Italy and Spain, have larger discounts, but other countries, that's what's in yellow, have zero discounts. So the question of the promise that they would get the best deal is not here supported. What can be done? And I won't go for time reasons into details, and I won't walk you through this slide. But what I would like to stress is there are different aspects and layers that can be used, and somehow they are overlapping. One is the existing policies, we know, they all have benefits and strengths, and there will never be an ideal solution. But existing policies could also be improved if, for instance, the methodology would be advanced. So this is one way, and that's the easier part. Another one, and we see that, for instance, in Europe now, is collaborative approaches in pricing, in HTA, so more and more cross-country collaboration. This is another area. And another area would be to look cross-sectional, so to look along the life cycle of the product. I'm also now speaking only on pricing. But it's important that, for instance, marketing authorization holders get into contact with the pricing people, because they require different data, but this could be then combined. And you see here at the axis the novelty, or you could also say the feasibility. And of course, some things are easier, some are for the future. And I would like to stop by mentioning kind of three overarching principles that I see as important for the future. One is collaboration, both cross-country collaborations of authorities, intra-country collaborations. Think, for instance, of hospitals, each of them purchasing on their own, collaboration between different authorities. Second, we need a debate, and it's good that we are here, with different stakeholders about the future role. And last but not least, I talked about the confidential discounts. I think, and I deeply believe, that it's absolutely important for the future to have more transparency, not only price transparency, but also we would need transparency on the real R&D costs, but also transparency on the processes by pricing and reimbursement authorities. So I stop here. I'm sure that there might be further questions, particularly on transparency.
And indeed, we will have more questions, of course, coming along our way. Thank you so much, Dr. Sabine Vogler, for this very comprehensive presentation that you have given us here now. Richard Sullivan, you're up next. Looking forward to hear from you.
Super. Thank you very much, and thank you to Andreas and Peter for the invitation. Let me just pick up where Andreas left off and just say for a moment before I widen this discussion out that the progress we've made in the science of cancer has been extraordinary. When I think about how I treated bowel cancer patients in the 1990s, anterior resections, the standard radiotherapy, a sniff of chemotherapy, 5-FU and leucovorin, and what we can do now for our bowel cancer patients is absolutely extraordinary. But the thesis I want to present to you all is the progress that has been made in the science of cancer and its improvement in outcomes across a wide range of cancers has been disproportionately enjoyed by high-income countries. What's essentially Olympic cancer medicine for Olympic patients in Olympic countries. And the test really of our real progress in cancer care, I would say to you, is not whether we can add more to this abundance, and we have got an abundance of new technologies coming through. It's whether we can provide enough for those who really have too little. So let me unpack this a little bit, because this is all about inequalities. And inequalities are foundational and fundamental, and they have a real danger of derailing the ability for us to deliver all these new innovations to our patients, not only in high-income countries, but indeed across all emerging economies. So I'm going to unpack it in 4 areas. I'm just going to go A, B, C, D, and you'll see what I mean in a minute. The first is availability here. So people focus an enormous amount on availability of medicines, availability of radiotherapy, etc. But I want to argue that the foundational problem at the moment in inequalities is the availability of good plans at country level. And I don't just mean good national cancer control plans. In majority of the countries we're talking about in low middle income settings, they do not even have decent national laboratory plans, national health resources plans, or indeed national financing plans of any sort. And there's a real deficit in that planning area, which of course demonstrates political will. The second aspect here is a massive and fundamental resource deficit for human beings. The people that will deliver the care, the trained surgeons, pelvic and general, the people that can deliver radiotherapy, the medical oncologists, the pathologists, the radiologists. And I won't repeat the numbers, many of you will be familiar with these. And this lack of human resources layers upon each other. This is the problem. We have a layered effect and a layered missing. The second thing I want to talk about is B, the burden aspect here. We do have substantial problems here when we think about risk factor exposure. Whilst we're getting risk factor exposures under control in many high-income countries, or making progress at least, what we're seeing, of course, is an exporting of pro-cancer risk factors to many weak and vulnerable low-middle-income countries. These are under the guise of bilateral trade agreements where there's no public health protection and other issues. So again, we talk about global solidarity, but then we don't practice it in the way we carry out our trade and our neoliberal economic policies. The other issue, I think, within the burden as well is the massive lack, and Peter may touch on this, of what we consider to be cancer intelligence. Whilst we have excellent data from many of the top high-income countries, down to the level of outcome data at individual hospitals and surgeons, it is pretty much a blank canvas in many countries around the world. And although you'll see a lot of data assigned to countries, most of this is guesstimation, it's modelling. It's basically black box modelling. We simply do not know what's going on. So that, again, that is a massive driver for inequalities. The third aspect around cost, and Sabine's already touched on this, is there is this huge inequality in the amount of funding that's available for cancer patients. If you think that cancer can only be built on reasonable and robust health systems generally, and then you look at the amount of money put forward to public total health expenditure as a percentage of GDP in many countries, it's woeful. And if you're not spending enough on your public expenditure, you cannot get good cancer outcomes, period. The other issue, of course, is catastrophic expenditure, and it would be completely remiss of me not to mention that. The inequality, economic inequality problem in many countries is because 60 to 70% of the expenditure is out of pocket. And of course, if you're having to spend your own money to actually get service delivery, what's going to happen? You're either not going to take it up, or if you do take it up, your family is going to be reduced below the poverty line. And even in countries that are making progress on social insurance models, and I will give you an example, Chile with AGE, Seguro Popular, where you're in Mexico, and indeed the new models coming through from India, are lagging behind. So they're not actually providing the financial protection for the real costs of cancer care. And then finally, and this is a slightly esoteric thing, so bear with me, it's this idea of distributive justice. We talk very sort of easily about health as a human right, but I want you to imagine for a moment you're a woman born in a country where you have to get permission from your father or your brother or your family to seek medical care, and you've got breast cancer or cancer of the cervix. The reality is you are going to present late, and late presentation in most countries, aside from the economic reasons and aside from the lack of facilities, is due to really embedded issues around distributed justice. That patients can't get access to this because they are refugees, because they are women, because they are poor, because they are poorly educated, or because they live in a tribal ethnic group in the Desanich in northern Kenya, and they're simply not on the political radar. So I guess when we think about innovations over the next 10 years. For me, it's all about closing the gap, and I think absolutely what Andreas said is correct, but it's closing the gap for our most vulnerable and underserved populations around the world, and that's what we really need to focus on.
Right. Thank you so much, Richard Sullivan, explaining the ABCD principle that you have brought forth, and we'll hear more from you, of course, in the second round. As we proceed. Julie Torode, Director of Special Projects. Special projects always sound quite mysterious. Very curious to hear what you have to say.
Thank you very much, and thank you for the World Health Summit to shine a light on global cancer issues. I'm very happy to join this panel. I'd like to go back to the statistics because UICC launched a World Cancer Declaration in 2008. And back then, we talked about the cancer burden and cancer mortality being at 7.6 million. And today, we heard the new Globocan data from iPRI. We're at 9.6 million deaths already. And these deaths this number is set to double in the next couple of decades. I mean, how many deaths do we need before this becomes a real public health emergency? We are talking about this all the time, and I don't see much action. Already, cancer is the #1 killer in some countries. Within 20 years, it's going to be the #1 killer in every country. That's quite frightening when we think back to what Richard's just been saying. Having said that, I am a half-glass-full kind of person, and I do think there is some progress to be reported. Yes, the data are still extrapolated, but there are many more countries now that have cancer registries and therefore have their own national data that are starting to shape the plans. UICC, with partners in WHO and the International Cancer Control Partnership, have just done an analysis of all the cancer plans in the public domain, and I emphasise in the public domain and not in a drawer somewhere in the Ministers of Health's office. There are now 87% of countries that do have some sort of cancer plan. And that's a starting point, which we didn't have a few years ago. Back in 2008, it was only about 48% of countries that had cancer plans. They do differ in quality, and when you look at them more closely, less than 50% of plans are actually costed in any way. And in fact, less than 50% of plans have any priority setting, situational analysis that's relevant to their country. So quite a lot of them are template plans. And also disappointing from the perspective of UICC, less than 60% of those plans have any engagement with local stakeholders. cancer societies, patient groups, even professional groups that should be actually helping implement that plan. So I think there's still a long way to go, and I think Richard's mentioned the divergence in ability to respond, and those countries that have good plans are focused and are ready to work with their communities are going to be the ones that can get that share of voice in national funding, but also in international funding, international help from technical assistance from other partners, and so that we're going to see a continuing divergence of these two sets of ready countries if we don't work to help those that still need help developing their plans moving forward. So I can't emphasise again the importance of the healthcare workers. Richard's articulated that very clearly, but we know the projected numbers globally there's going to be a gap everywhere in any country. So how do we get those workers from Africa who are working here in Berlin back home, working where they're needed most, and make sure that we're building the health systems in countries that need the most help?
Thank you so much, Julie Torode, for this view from the UICC. We started the introductory statements with co-chair Andreas Penk, and we will wrap them up with the second co-chair of this session with Peter Boyle, president of the International Prevention and Research Institute. Peter Boyle, you're doing it standing or sitting?
Oh, standing.
There you go.
It's a more difficult target to hit. First of all, I'd like to thank the organisers for inviting me, for organising this important panel and panel discussion. It led on from a very, very exciting panel discussion that we had last year. So I'd just like to now figure out how to make this go ahead. No, that's not it. So, yes, the world's changing. This is the total population by regions. It's from the United Nations Populations Division, and it's the population from 1950 up into projections from 2100 around the world. And you can see that the huge change, there's not going to be much difference, much change in Europe or North America, Oceania, Australia, etc. But Asia is already increased, we know that. It's going to remain fairly constant, but the huge change is going to be in Africa. It's going to be enormous changes in the population of Africa coming up. My estimate, our estimates we published in 2008 of the global cancer burden is going to be 27 million new cases in 2030. And you've got to remember these are estimates. And one of the problems of estimates, and Richard came on to it, is that they are estimates. I mean, GlobalCan gives you an estimate of the number of cases of cancer. It's great, but it's still an estimate. It's an estimate based on estimates, and some of those are based on guesstimates. So goodness knows if it's correct or not. And with GlobalCan, I've been speaking to ministers in different countries, in low-resource countries, about cancer registration, about recording deaths. They don't want to do more cancer registries because we've got GlobalCan. We know how many cases we're going to have. So in actual fact, in absence of creating more real data, we're going to continue with estimates. Even worse is the global burden of disease, which pretends to give estimates of all diseases and all mortality rates and everything in different countries. And that is stopping the many, many countries in the world from having medically certified cause of death schemes. We do not know why people die in many, many countries of the world. We've got estimates based on estimates, based on estimates and guesstimates. So I think we've got to be very careful and make an effort to try and collect real data so that we actually know what's going on. So as a result of innovation in prevention, innovation in treatment, these are the mortality rates that we see in men in many countries of Europe, North America, with Canada, England and Wales, France, Germany, Italy, Poland, Russia and USA. And the mortality from cancer is coming down in men and also in women. These are on the same scale, just to show you the difference in the rates between. You can see even here in Poland and Russia, it started to come down, typical of the very eastern countries in Europe, started to come down about 20 years after that in the rest of Western Europe, and the rates are still higher, but they're going in the right direction. There was a wonderful report to the European Commission, public grant funded by the European Union about 15 years ago, which showed a huge division between health in Central Europe, the new member states and the former member states. But when we look at Africa, the situation in Africa is absolutely horrendous just now, and we're going to see this huge explosion in the population taking place this century. We wrote a report, which we presented at the meeting last year, and it's written by people working in Africa, our friends, people living in Africa and working for Africa, and people who are working with people working in Africa. And it presents an amazingly depressing and deplorable picture. There are too many patients do not seek or cannot access professional medical services. It's cheaper to go and see Richard's example of this girl who had breast cancer, needs all sorts of advice and approval to go and get something done. You know, and it's easier to go and see the faith healer and get something from them and give them a chicken or a couple of carrots rather than have to pay money for any prescription chemotherapy drug in Africa. And apart from the high cadre and the people who can afford to go abroad for treatment, everyone has got to pay for their drugs in sub-Saharan Africa. And most patients with cancer cannot even afford the money to pay for the simplest schedule of chemotherapy. Those who present at stages where the cure is no longer possible and palliation is impossible because there's a lack of radiotherapy and there's a lack of palliative care, opioid therapy for treatment of pain. Africa suffers from a lack of oncologists in all disciplines, and nurses and technicians, and they need all the basic health professionals to support their work, and they are not there. It's anecdotal that there are more nurses born in Malawi working in Manchester than there are nurses in Malawi. There's a lack of treatment centres, there's a lack of treatments. Most countries don't have, 30 countries don't have radiotherapy equipment. I was chair of the review committee for the International Atomic Energy Agency medical projects in 2003. I wrote the letter on behalf of the committee to Professor El-Baradei, who eventually agreed. And what we said was that the PACT programme should be the #1 programme. The PACT programme was designed to give and place radiotherapy machines where no equipment was available, and that has been going very, very slowly. There's 29 countries in Africa it's legally forbidden to import opioid drugs. And I can assure you, if you're dying a very painful death from AIDS or you're dying a very painful death from bone pain, all that exists is Tylenol, and I can assure you Tylenol is not effective against the pain that's caused by cancer. In this programme, the situation is bound to get worse as the population grows and ages, and cancer risk factors, like Richard said, imported from high-resource countries, begin to have their effect, adding to the local risk factors. 50% of cancer in sub-Saharan Africa just now is caused by a chronic viral infection. I could say a lot more. I just want to make the case that we're here, a World Health Summit. It's a World Health Summit. It's not a European Health Summit. It's not a Western European, North America Health Summit. It's a World Health Summit. We've been remarkably successful with innovation in reducing the mortality rate from cancer in many high-resource countries, in most high-resource countries, but we now need to turn our attention and find some way of innovating what we can do for people with cancer in low-resource countries. Thank you,
Peter Boyle, for concluding this round of introductory statements. Andreas Penk, everybody here on this panel has focused on the need to strengthen the fight against cancer in low and middle income states. Peter Boyle just stressed and emphasized the deplorable situation in Africa. Now, the fight against cancer in low and middle income states obviously cannot be done without the pharmaceutical industry, having them on board. What is the role of the pharmaceutical industry here in order to strengthen the fight against cancer in those particular low income states?
I mean, we have heard it already from Peter Boyle that the picture is pretty depressive, and it is not just the lack of one thing or the other thing, but it's the lack of almost everything. And this is where we really need strong collaboration. And I would then ask also Julie to comment, because there is a very promising project underway with UICC in these countries, where it's more about strengthening the system to make sure we can finally provide some kind of cancer treatment, even if it is a kind of basic treatment. And this is important to understand. We have an opportunity to create a system where patients get access to what we would call the basic treatment. At the moment, basic treatment is not available. We heard it from Peter Boyle. There are no opiates available in 30 countries in sub-Saharan Africa. And it's not the price. It is forbidden to import. You can get it for the price of a slice of bread, the daily dosage. So it is not the price. It's simply not available. It's the healthcare professionals are not there. The machines are not there. There's no infrastructure to supply the drugs. So we partnered with American Society of Cancer together with an Indian company also to provide cytostatics to Africa. However, who will finally prepare and administer the cytotoxic drugs? It's not easy drugs. It's not aspirin you can just give to somebody. You have to prepare that, and it's, by the way, a dangerous thing to do. People need a lot of training and special equipment to prepare cytostatics for administration. There's nothing there in Africa to do that. So we need first to establish these things, and that's why we have a big initiative where I think more than 20 pharmaceutical companies collaborate. Accelerating Access is the name of that. And we collaborate with USCC, with World Bank. So really to make sure we can first build a kind of a basement. And once the basement is there, we can step in with, and we are ready to step in with many initiatives around our medicines. But at the moment, there are really priorities around all what I described. And one last point, I mean, is in that report Peter has shown. In sub-Saharan Africa, just to describe the magnitude of the issue, 19 out of 20 cancer patients never see a healthcare professional in their life, so to say. They just stay in their villages and that's it. So only 1 out of 20 makes it to the next city, to the hospital, and sees a healthcare professional. So this is the situation. They couldn't care less about whatever drugs and diagnostics. They need very basic things, and we need to fix that. And I'm very hopeful with the project we have with UICC and some others, by the way. So the basic requirements, basic necessities are still missing. And you said you're hopeful. I mean, Julie Torode says she's a glass half kind of full person. Would you subscribe to that? Are you, despite the many the lacks that we see, are you still hopeful? I mean, I know, for instance, there's one oncologist in Malawi, in this country of 16 million people or so. It's just one oncologist. So this could be a very pessimistic message. I know this one oncologist and know his personality. That is the optimistic part. I have never met a more optimistic person than this one single oncologist in Malawi. So there are people out there in Africa. There's a support network on the globe. It's not only about Africa, by the way, but this makes me more optimistic, so to say. But it's a huge amount of work, and nobody should expect quick relief here, and that's important. If we embark on that, and we have embarked with USCC and others, we need to really make sure everybody understands this is a long-term thing. It's a long-term journey, needs our commitment over many years to come. But then I'm optimistic. But we are committed for many years to come. A long-term joint effort is needed here. Dazhu Yang, you were kind enough to tell us how nuclear medicine can contribute to combating cancer. Would you care to share some specific examples, some of concrete results the IAEA has achieved in this particular field? What have you come up with since 2004, I believe, since you have undertaken this effort? First of all, I'd like to comment on the information just provided by Peter. The
the information on the situation in Africa is very true because before I took the current position, I was director for Division for Africa in the Technical Cooperation Department. The situation in Africa, in particular on the cancer control, is very, very challenging. But good news is now several governments already realized the importance and the urgency for actions. In particular, some African first ladies, now they met regularly and raised awareness of cancer in the African continent. And the IEA is supporting this kind of actions. Yeah. And the IEA has so-called regular program and also technical cooperation program. Yeah. Under the regular program, we have also the sub-program on health. We have one division with 3 sections on nuclear medicine, on radiotherapy, on nutrition using nuclear technology. On the other hand, under this program, so we organize many international conferences, we coordinate joint research, and we also develop some training materials for the human resource development. And we also have a data bank to include all the information about the radiotherapy services and also nuclear medicine facilities around the world, which is very important. Another program is a Technical Cooperation Program, the TC program. And this is I have to say that almost 1/4 of the program is focused on human health, in particular cancer control. I can give you a very concrete example. So several years ago, I paid a visit to Indonesia. I was invited to visit a cancer facility. And the head of this department of radiotherapy told me his journey. Yeah, he's a medical doctor, but 20, 30 years ago, he had no knowledge about nuclear technology for cancer diagnosis or control. And he attended some IEA conferences, workshops, and he learned that nuclear technology can play a very unique role in the diagnosis and treatment of cancer. And then he asked for a so-called technical cooperation project, a national project to help the country to strengthen or establish the very first radiotherapy center. And then he used all the means we can provide and to support this effort. One of the activities is so-called scientific visit, and he's very smart. He invited the deputy minister for health and also some important persons in the Congress, and to attend some missions, meaning to visit some other developing countries. They used the nuclear technology for cancer control, and to convince them that nuclear technology, the radiotherapy, can play an important role. And then he also used another means of our program to invite experts to help them to design their very first radiotherapy center. And also not only design the center, but also to help them to choose the right equipment, and also the human resource development plan. Then he used another means, that means the fellowship program, the 6 months fellowship program, the 1-year program, and by that we help them to train the people. Yeah, and then he got the money from the government, and he started the construction of the facility, and he received advice from the agency about the procurement, and then he procured the equipment, and with the trained people, they started the facility. And then he repeated the cycle again and again. Now, when I was there, this was his 3rd phase of his department. This is an example how a country can benefit from the IAEA's technical cooperation program.
Thank you, Dazhu, for sharing with us this very specific example. And thank you also for letting us know about the Program of Action for Cancer Therapy, the PACT, which is a program created by your organization in 2004. Sabine Vogler, we have heard a lot about Africa and about the regrettable situation over there. When we talk about the WHO and their fight to fight cancer, are there any specific regions where the WHO is particularly active?
Yeah. First of all, as you're addressing the question to WHO, I would like to stress I'm not WHO, but the WHO Collaborating Center, because sometimes, I would say with regard to different regions, WHO is global, and I'm not now talking about what are the focuses of WHO, but what we would also need to consider are the emerging countries. There are sometimes, and I'm not talking from WHO perspective, there is sometimes a focus correctly on very low and least developed countries, but the middle-income countries are also countries that need to be considered. That's now my perspective, not, as said, not talking for WHO. Also, when we think about these are countries that are working to make progresses to universal health coverage. And universal health coverage does not simply mean, okay, we build a social insurance, that's it. But it's a long journey, and part of this journey is not just we have some money here, but we have money, but of course money is limited, and we now have to make a very strong prioritization, and in this prioritization, making some planning. What is the public health perspective? What is important? The medicines, the equipment, the curricula, the staff, all this is important. And I would like also to talk a little bit about middle-income countries, because I see that middle-income countries are looking at high-income countries. Of course, it's clear seeing what the high-income countries have been doing, and it's more than legitimate to look at them and maybe to learn from mistakes, so that it doesn't take them too long, 40 years to understand, but to have that quicker. But I think with regard to certain policies, it's also the responsibility of high-income countries to say, okay, this did not work that well. Be very careful. And I'm a little bit coming back to the issue which is very close to my area of expertise, the pricing policies. I think messages have been now made very well to middle-income countries, low-income countries, about the importance of coverage, of the importance that to ensure that patients do not have to pay everything fully out of pocket. It's unaffordable. But some policies which are the newer policies with high-income countries, like these managed entry agreements I have been talking about, they are now looked at by middle-income, sometimes low-income countries, saying, oh, you have these policies. It's a super way how you can get lower prices. We also want to have that. Let's go and have our legislation changed. And I think here also an important dialogue should be done with these countries. I know they are sometimes not too happy to say, when I say, well, be careful. Look close. We have our problems in the high-income countries. Look at the evidence, look at the patients, and be very careful when taking over our policies, and listen. Do not do a copy-paste, but listen and analyze your system. I think a key word, talking about cancer, talking about other diseases, a key issue is, and this covers what all of you have been saying, healthcare system strengthening, covering all these aspects, and this is important.
Thank you so much, Sabine Vogler. Richard Sullivan, it's been said that here on this panel that innovations are evolving at a very rapid pace. But of course, the access to these innovations is unevenly distributed. How do we ensure that the innovations that we're talking about and raving about are being enjoyed by a vast majority of the population?
I have to say I dislike intensely access because the problem is it hides what are incredibly heterogeneous situations in most countries. And I want to just reflect on what Andreas was saying about role of pharma. I think a lot of companies are waking up to the fact that if the basics of the national cancer control plans aren't in place, you're on a high road to nothing. You know, if you're getting surgery where it's R1 resections, in other words, it's leaving cancer in, it's not fully resected, then it's a waste of time giving any form of drug because you've still got macroscopic disease in there. And actually underpinning all of this and the access issue is an idea that actually you can have some form of global solidarity in cancer. But the evidence at the moment doesn't support that. If you look at overseas development assistance, and this is the majority of money flowing to support health system strengthening, less than 10% is dedicated to NCDs. And of that 10%, if you're lucky, you can probably identify about 20% of that 10% goes into cancer, okay? So let's not fool ourselves here in terms of helping solidarity. We talk about access an awful lot, and yet we do not follow the money and put the resourcing in where that's concerned. And there are, indeed, it's embarrassing really when you think about how much money is actually spent on cancer care in high-income countries and indeed on research in high-income countries that somehow never makes it out in any form of solidarity. And Peter has a meeting every year, the National Cancer Institute of Directors, where are phenomenal twinning models available, where individuals like Pat Lower from Indiana with Eldoret, colleagues from UNC and SMU working with my friends in Zambia, and developing some really major improvements in outcomes. So these are really long-term solidarity programs, which actually is the whole point. It's not about access, it's actually building up the pathways and the models of care. But I'm going to be blunt with you, these are few and far between. We see them in childhood cancers, with child cancer, with St Jude's, etc. But there is simply not the focus in global health, which is focused on child and maternal mortality, infectious diseases at the moment, and there's just simply not the bandwidth and interest. And I'm going to finally end up by saying that part of the problem, though, is with cancer community. We've been utterly lousy about engaging with ID and child and maternal mortality. We've not been good about looking outside our own black box area. So access, if we just keep on talking about access, I don't think we're going to see any progress in either public policy or outcomes. I think we need to widen this out, talk about improving patient outcomes through some idea of solidarity, which is actually properly funded across the board, both in public and in private sector.
Thank you so much, Richard Sullivan. Julie Torode, in your introductory statements, you've already mentioned that the UICC offers a very broad variety of projects, of course. I read about one in particular, the City Cancer Challenge, and its goals. For those who may not be familiar with it, can you describe what's new and innovative about that particular approach?
Yes, before I do though, could I respond to some of the issues on the panel? Because access to opioids is an absolute fundamental for every cancer patient. And as Peter said, you know, the access in many low and middle income countries is just not there at all. Your morphine has been around for over 200 years. It's as cheap as chips. The problem, though, there is not around knowledge. It's around the intersection between health and drug regulation. So you have to look at the policy challenges before you can solve the service challenges. And I think we have the same in many cancer issues. You've got to look at where the bottleneck is. You've got to address that and then follow through. And the connectivity issue is fundamentally what UICC is trying to look at. There is no point having medicines available if you cannot diagnose the cancer and get the indication right first. So the City Cancer Challenge is really looking at trying to look at the smallest unit that a country would need to start to build capacity for dealing with cancer, both from the process side and the quality side. And that is one place, a cancer centre, which is not just one hospital working on its own, but connected to its community with referral right through to the primary healthcare level. And so we're working with cities because we think there might be more connectivity from the city leadership with those people that are living around the city. There might be different funding mechanisms for that hospital to seek that sustainable funding that is also very much lacking. And we've had some good success there. And this is by no means a big program at the moment. We've looked at working with 4 cities, which we're calling our learning cities, working out how we can be helpful. And one of the things is just bringing the right stakeholders to the table and discussing what the issues are. So many times people have said, this is the first time we've actually all sat together and spoken to each other together. It's been impressive, actually, how the first city, Cali in Colombia, has within 12 months gone through that process, worked out who does do some sort of cancer treatment in that city, and started to look at where their strengths and weaknesses are, assessed gaps. They now are developing a 3-year plan to try and assess that. And what we're trying to do with the City Cancer Challenge is bring in partners that can respond to that issue. So trying to connect everything together. So if they're prioritising pathology, we're working with international groups that can help build capacity and have that longer term connectivity with the centre to make sure that any initial work done is then carried through. As I said, it's still in an early stage, but we have 4 cities, one in Africa, in Ghana, in Kumasi, just getting going with that process. Asunción in Paraguay is just following shortly after Cali. And Yangon in Myanmar. So very much in different regions of the world as well, so that the learnings from those cities can be shared with others. And just recently, we've gone out to other cities to apply to be part of that process, use the same tools, but with less hand-holding to see if we can start to now extend that to many more cities. So it's a start of a process. Someone said we've got to go, I think it was you, Richard, got outside of our cancer box. Well, one of the ways we can do that with cities is there are many city initiatives. And what we've learned from other city initiatives is the cities start to help each other. And you don't even need to be involved after a while. So there's cities looking at environment, safe cities, all of these issues and learnings can come into helping move this project move more rapidly. So it's a new way of working. It's trying to bring all the international help that we do have in the cancer community together in one place, including the private sector. So we're looking forward to seeing it bear fruit.
All right, thank you, Julia Torode, for informing us about the City Cancer Challenge and its goals. I do want to get the audience involved. We have approximately 20 minutes left, but before we do, Peter Boyle, you have shown us the numbers, you have shown us the figures here when it comes to Africa, and Julie talked about the policy challenges. Tell us about the policy challenges in Africa. How do you create awareness on the policy level there?
Well, it's a good question. We're going to launch at the beginning of next year. We've organised with about, I think we've got 30 participants from different countries in Africa. It might be 25, it might be 35. And we're launching a campaign for awareness. We've created various materials that have been approved locally. We're on the agenda for the health ministers, the African health ministers meeting next May to discuss the whole awareness and the work that we've been doing with the National Cancer Institutes, etc., etc. And that's all very well. But, it's okay to have a policy, but how do you do something about the policy? And I just wanted to get something out of the machine here, and I'll read it out because it's very relevant. I think what we need now, as you say, is a policy and a programme of action working together. There was an International Covenant on Economic, Social and Cultural Rights, ICESCR, which was voted by the United Nations General Assembly in 1966 and became in force in 1976. This was a multilateral treaty, provides that state parties to the Covenant recognise the right of everyone to the enjoyment of the highest attainable standard of physical and mental health. Article 12.2 of that covenant contains important determinants of the right to health, such as prevention and treatment of diseases essential for the enjoyment of the right. There's 164 parties, countries have signed up to that. And nothing's happened. So what's the point of having policy and having legislation and having rules and having covenants if nothing happens to them? And I think one of the things that we've got to do is to get away from this, as Richard said, there's no, I agree with Richard, I'm sorry Julie, I disagree, but there is no coordination of the global cancer effort. There's none at all. Whether it's from governments or NGOs or whether it's groups, they've all got their own little silos and they're working out, some doing great things, but there is no coordinated action. And even you now go to the United Nations and say, this must be done, everyone has got the right, 164 countries agree to it, we must have the right to health and to promote health and everyone with the same standard of health. Nothing has happened since 1966 or 1976 with that. We don't need international legislation, we don't need a framework convention, we don't need that, we've already got it, but nobody uses it, blah, 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 hot air. Policy, 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 but we've got to implement it, and that's the difference. It's like Nike say, just do it.
Less talk, less agreements, more actions. Now, ladies and gentlemen, for the remainder of the session, it's become abundantly clear that we have a great deal of expertise here on this panel, but I do know that we have a lot of expertise and interest here in the audience as well. I would like to make use of it. We have microphones coming to you, so please indicate if you have a question. Right here, the lady in the middle with the laptop, please introduce yourself quickly, and it would help if you could address your question to one person in particular. Go ahead, please. Microphone's not working yet. Let's give it another shot.
Is it on now?
There you go.
Hi, my name is Jenny Vaughan. I work for Stop AIDS, an NGO based in London. Sabine, you mentioned this briefly, so I wondered if you might expand on the Knowledge Ecology International / Jamie Love's idea of creating a de-linked cancer innovation fund, which would conduct a feasibility study of how a de-linked model could benefit our ability to treat cancer based on principles of affordability, transparency and open access to knowledge.
Right. Anyone in particular you would like to hear from?
Thank you. Does it work? Yes. Thank you very much for the question, and I think you're really entering in the heart of the discussions which have been, ongoing and not just for the cancer area for the last 20 years. And the idea is how to organize or reorganize the whole system of not only pricing but supplying medicines. And you saw it maybe in one of the slides. I deliberately do not use the word delinkage, because I do not like the word delinkage because it kind of suggests that the prices are linked to R&D costs, and as we do not know. So what Jamie Love says and several others is in fact finding new ways of incentivizing that the medicines that we need are put on the market, and it has been discussed for quite some time. And here again, I'm a little bit coming to what Peter was saying. We see that this has been discussed for a long time, and then there's the discussion, why is it not being implemented? And there have been some, let's say, pilot initiatives, and I think now this is also a way to move forward and to come from this discussion to a kind of an implementation, because the discussion has been ongoing for quite some time. Richard. And I think now maybe one word is I feel that this discussion has been ongoing for a long time, but it has always been seen as the part of low and middle income in countries, and high income countries were not interested. Now, even high-income countries get interested in that, but capacity has to be built.
Thank you. Richard, just quickly, you want to add on that?
Yeah, very quickly. That's a waste of bloody time, all right? I keep on saying this to people and I'm blue in the face. The problem in countries is that the drugs are not there. The people are not there to deliver them. We're awash with good cancer drugs out there, current and old ones. So it really drives me nuts, this sort of thing, because it really distracts from the real problems that are actually experienced by many of these countries.
Next question, please. The gentleman right there. Please introduce yourself. And if we can keep the questions and answers brief. I've seen quite a few hands up.
Professor of Surgery and Oncology, Pavelkis, Lithuania, Kazakhstan. I would work on Richard's saying, and everybody knows that surgery in cancer care gives 90% of result. And education of surgeons was not mentioned here. So it seems if the patient in Africa will not get some sophisticated bio-treatment for cancer, all the Africa will die. I guess the main reason is education of the proper surgeons in the region. So would you like to comment on this? Thanks.
Thank you. Absolutely spot on. Quick thing, say Global Surgery Commission from the Lancet, Global Cancer Surgery Commission as well that came out from the Lancet Oncology, and you're spot on. The issue here is about training both pelvic surgeons and general surgeons, and also then retaining them, as Peter said, in country. A lot get trained up, and we had this discussion with the Western African College and COSEXA as well, and they simply depart because the conditions aren't good enough. So it's, there's a lot of focus on the deficits in infrastructure, so safe anesthesia, oximetry, etc., and instrumentation, but it's the human beings that need treating. And I agree, there needs to be a major improvement in program. There are lots of good demonstrator projects out there, but as it stands at the moment, I think when you look at public policy, the surgery is slipping well behind at the moment in terms of upskilling where that's concerned. So I think you're spot on. Thank you for bringing that. And I mentioned within that pathology and imaging are crucial as well. It's no good talking about the surgery and anaesthetists by themselves. Peter?
Just I completely agree with Richard for once. And I think, but it's not only surgeons. We need nurses, we need anaesthetists, we need technicians. And in Africa, the rate of infections and deaths, 30-day deaths after surgery is really very important to tackle. So it's a whole package, but we completely agree surgery has got to be the basis of it. And we're trying to look now to see if we get national surgical plans for the low-resource countries, but they don't exist.
Also, may I just quickly say as well, in high-income countries, we're spending too much time teaching our juniors minimally invasives and robotics. And what we're losing is the skill set in open surgery, and that's a massive problem in global solidarity if we're losing those interface skills.
In the interest of time, let's combine the last three questions. So we have the gentleman over there, we have the lady to the left side, and the gentleman here in the first row. Time-wise, I think, realistically speaking, that's as much as we'll be able to squeeze in. Go ahead, please.
Anthony Renshaw from International SOS. Now, there are a few examples of forward-thinking companies who are providing preventive health services, including cancer screening, to sometimes up to 100,000 people across the world, from Ghana to Kazakhstan. Now, in the context of the SDG 3s and businesses wanting to be seen to be a force for good, are we not missing a trick in promoting this in more companies, and how could we build momentum in the private sector?
Thank you so much. The lady on the left side.
So I just wanted to comment, Sharbani Chakraborty from Hoffman La Roche. I just wanted to comment on what you said, Richard, because I think if we want to really scale up action for cancer, we need to be talking about co-creating solutions. And so to go back to what City Cancer Challenge is doing, the question is, how can we do more of this faster? Because we cannot wait. Thank you.
Thank you so much. Last question. Go ahead, please.
My question is
Can you introduce yourself quickly?
Yeah. My name is Dr. Dabr. I'm working here in Germany. I'm a gynecology oncologist, and I'm working here in Germany more than 20 years. In this experience, what in oncology, what we have done is that we have started about 8 years a program to train in Ethiopia, in West Africa, fellowship programs. And in these fellowship programs for oncology and gynecology, we have made it with the Gynecology and Obstetrics Society here in Germany and we have trained more than 6 fellows. So in the way of skill training on knowledge, and what I have observed is the big problem is the knowledge on the skill. Therefore, I think what I just say is, please, when you have the knowledge, give a correct knowledge to the other countries to transfer it. Because the skills you can teach it in a very short time. It's not very, we teach it in a very short time, the skill. Therefore, I think we have to go in this way. The other big problem, what I am seeing, I am really concerned there is with the radiology. I want to ask you, it was really difficult. How can we bring radiotherapy in these countries? First, there are problems. The big problem is because the electricity problem, the regulations, these are very, very difficult. And I'm really asking, is it possible for these countries in the next 20 years even to have a radiotherapy centers in Africa? I am not sure. I'm doubt. Probably when you have the knowledge, please solve these problems with radiotherapy. The other problems with chemotherapy, you can do it with simple, it's not a big problem. The chemotherapy, the opioid therapy, it is possible to do it. We can change it. But the big problem, what we see is the middle class of the society who are really moving, who are having a better life. Now they are moving to other countries for therapy. Then we are just taking the whole money to other countries, and the development is going down, and the other countries are going to stay poor. Right. Therefore, I think we have to do that. I just want to know how this big knowledge, how to transfer it. Right. The skill on the oncology knowledge, I think it is not a big problem. Wonderful. Everybody dedicated can do it.
Let's throw it back to the panel. Thank you so much. Now, we're quickly running out of time, but Andreas Penk, which of the questions would you like to address? I think we're missing a microphone here. If you could pass it down the line. Wonderful.
No, I think we have talked a lot about the situation in Africa, and I think it was quite comprehensive, if I may say that. When we talk about the sustainability development goals, the SDGs, the private sector and the pharmaceutical industry, we have been committed to support this. This has been, by the way, reconfirmed by the United Nations General Assembly just recently, and it has also been reconfirmed by the President, the General Secretary of WHO also recently. I think it was the first time that this was noted in the General Assembly of that organization, that the private sector is a key partner. We think we cannot do it alone. I mean, once again, when you go into such areas, you need to broadly collaborate, and it's not that just one player can do it and say we go there and we will change the world, etc. It would be fantastic, but it's not working that way. We need to collaborate, and it's mainly collaboration with governments, with a lot of other players in the respective countries. And of course, this includes also a lot of NGOs, by the way. So the collaboration will be absolutely key, but we are committed to support the SDGs. I mean, the industry has not been clearer and stronger on that since the past few years. And we mentioned it already. We have projects ongoing. So it's really encourage and invite everybody to really look at IFPMA website, for instance, is our global pharmaceutical organization, or the websites of the pharmaceutical companies. We have these projects and initiatives ongoing. We mentioned the UICC one. So it's maybe also sometimes just lack of information.
Julie, did you want to add to any of that? Any question that you would like to address?
I think Peter wanted to.
I just wanted really to address the issue of screening and say that I think what you're describing is actually a waste of time and quite dangerous. We know from screening that colorectal cancer screening with the FOBT will reduce mortality by about 10%. Sigmoidoscopy will reduce incidence and mortality. Colonoscopy is the answer. You can run every 12 years and you're fine. We've got good evidence that cervical cancer screening with either a pap smear or a HPV testing is very effective. We're very concerned about breast cancer screening just now because the mammography screening is probably overdiagnosing women by about 40% and leading to no improvement in their lifestyle. We haven't really taken into account the huge changes brought about by simple chemotherapy. Prostate cancer screening, if you do prostate cancer screening in a general population, I think you should be put in prison because the negative effects of that far outweigh any positive effect. There's no other type of cancer screening which has been shown to be effective, lots of people look at it as a money saving and a good idea, a money generating and a good idea, but really and truly it is not. It is not.
Thank you.
I would just... Is this on? Yeah. Just to answer the question from over here, I think the tipping point will be when we actually have some cancer survivors that can speak up for new patients in their country. One statistic we haven't heard about today, the 5-year prevalence of people living with cancer is 43.8 million. But many of them are not in low and middle-income countries, and even if they are, they haven't got the voice that has driven the change in high-income settings. Having said that, I've met many African women who've survived breast cancer for over 15 years now and are starting to be the driving force for a patient voice in these countries, and I think we need to support them. But make sure that they're also focused on this health system story. There's no point focusing on one single cancer or a particular access to a particular drug. We've got to get the health systems approach. And UICC is working with its membership to try and make them more articulate in talking about health system change.
Thank you. It's 3:30. I'm looking at the panel one last time. If there are any last words, that doesn't seem to be the case. Peter?
Just do it.
Just do it. Wonderful. Not sponsored by Nike, of course. This is just... There you go. There you go. Let's talk more action, ladies and gentlemen. I think I speak for all here in the audience when I say this has been a very content-rich debate. It's become abundantly clear that progress is there, progress is being made, but clearly a lot is still left to be done, ladies and gentlemen. Please join me in thanking this wonderful panel, Managing the Next Decade in Cancer. Thank you.